he's my dad. So we're a father and son team of cardiologists, and it is indeed an honor for me to be able to introduce my dad and be chairman of a meeting. So when this was initially proposed that he would come in and give a talk, we thought this might be an ideal opportunity for me to chair a meeting in which my dad is the main speaker. So for me, it's a great honor, among other things. To some of you who may know him already, he is an interventional cardiologist. We work in private practice together and have been doing so for a number of years. The primary practice has always been in Mount Elizabeth Hospital, but that is changing in the coming months, and as of January next year, we'll be 50% out of each side, and Dr.VP Nair will be here 50% of the time, and myself the other 50% of the time, covering our clinics here in Mount E Novena. So as an introduction to him, I've got his CV here, and it's the first time I've been given a CV of my own father to read out to everybody. But basically, he's an interventional cardiologist. He's been in Mount Elizabeth and been in practice in Mount E probably for almost 30 years, with an extensive wealth of experience, having treated all kinds of cardiac disorders. He has worked in a number of places, including England and the US, and you can see there's a number of different countries behind each of the titles. So that's his experience, if you will, starting out with the UK and moving on to a number of different places, including the USA. He has been doing the PBM, which is an honorary title by the Singapore government as well. He has published numerous scientific papers, has been involved with a number of conferences all over the world as well, and he gives regular talks and lectures at CME. He has been the president of a number of different associations, including Rotary, and is a chartered president of one of the clubs here, Rotary Orchard, and is involved very much in community work as well. The topic today is about management of significant coronary artery disease, medical or interventional. And this is an interesting topic because it depends on what your definition of significant coronary artery disease is. Most of the time we take it as being more than 70% blockage in an artery or a coronary artery. Sometimes this definition varies depending upon the other tests that have been done as well, whether it's due to tests to look at myocardial perfusion, whether we use wires across the lesion to assess the pressure gradient across the both, and he will go through all this in detail as well. But what we haven't identified, among other things, is which plaques are likely to cause a myocardial infarction. We always talk about the vulnerable plaque, and we do know and we understand that 50% of cardiac events occur from blockages that are less than 50% stenotic in nature. So that's the whole theory behind the vulnerable plaque, and there's a lot of imaging modalities that can be used to identify this plaque, among other things. But at the end of the day, there's a simple definition of what is significant coronary artery disease, which is basically what causes symptoms, or what is shown to be on several tests significant, such as a pressure wire assessment or an ischemic assessment of the heart with nuclear perfusion scans, stress echoes, etc. And all this Dr. Nair will be going through in the course as well. So I'm about to introduce you to Dr. Nair. Before that, I've been asked to do a little bit of housekeeping, if you will. There's apparently a GP symposium on the 31st of August, and if anybody wants to register, they've got all the documentation in front there. This is on 31st of August 2013, which is Saturday, yes? Anything else I need to tell them? No, that's good enough. You'll do the rest? Fantastic. Okay, as mentioned earlier, Dr.VP Nair is an interventional cardiologist with a wealth of experience. We work together in private practice, doing intervention as well, and he's going to go through management of significant coronary artery disease, medical or interventional. Dr.VP Nair.
Good afternoon. Thank you, Dinesh, for that wonderful introduction. It is often very rare for a son to introduce the dad. It's just like Lee Hsien Loong introducing Lee Kuan Yew. But the difference is that I had a similar opportunity some time back to be the chairman in the World Congress of Cardiology, where my uncle K.G. Nair was giving a talk. So this is the reverse of the same thing. But having said that, I just want to start the talk with a little bit of thing. Now, I thought I will take you through the history of angioplasty and stenting. As you can see here, PTCA was, or percutaneous transluminal coronary angioplasty, was started in 1977. That is about 36 years ago. Then came the stenting problem, and BMS, that is bare metal stent, was introduced in 1986 by the French researchers who implanted the first stent into human coronary artery. And in the same year, in 1986, Paul and Sigabert implanted the first coronary stent in a human patient. At that time, I was in Brompton Hospital and I was with Sigabert, so I had the experience to see the first stent in the world. In 1994, the FDA in USA approved the first heart stent for use in the United States. Now, the first stent to be used was the first generation stent called sirolimus eluting stent, or cipher stent now is no more used. It was used in 2002. Now we have a new thing called a bioabsorbable vascular scaffold, or ABSORB, which of course is started in 213 in Singapore. I'm sure you can identify some of these doctors here. For the first time in Singapore, we had our first course in the techniques of coronary angioplasty and intervention in 1989. You can see myself here, if you're not mistaken. This is Arthur Tan, this is Koh Tian Hai, and you can see the old guy, Johan, who passed away recently. So having said that, I'm going to show you that I addressed the World Congress of Cardiology, where I was the chairman and my uncle KG Nair was the speaker. But having said that, we started moving from there, and we started angioplasty, and stenting became one of the common things for blocked coronary arteries. Then came different trials. One of the trials is called COURAGE. COURAGE, or clinical outcome, utilizing revascularization and aggressive drug evaluation in 2006. Followed by COURAGE nuclear substudy in 2007, BARI 2D, remember BARI 1 was there, but this is 2D, bypass angioplasty revascularization investigation in type 2 diabetes trial in 2009, FAME 2, that means fractional flow reserve guided PCI versus medical therapy in stable coronary arteries, and then of course in 2013 we have up-to-date guidelines. Now, coming to the next one, you must remember that these are the two guys who put a storm in a teacup in the year 2006 at the World Congress of Cardiology, and they say that there are too many angioplasties done and medical therapy is almost as good as angioplasty, and that took a shock for most of the cardiologists, and of course they are not 100% right, but this is still valid. But what is the treatment in COURAGE? Do you know that you can have a pharmacological treatment in the form of antiplatelet aspirin, clopidogrel, simvastatin or atorvastatin, ezetimibe or one of the statins. ACE inhibitors, those days only simvastatin was available. ACE inhibitors or ARB, beta blockers, then calcium channel blockers, nitrates. But more important, of course, is the lifestyle, such as cessation of smoking, exercise program, nutrition counseling, and of course, weight control. Now, freedom from angina during the follow-up of the number of needed treatment for GTN was compared in both the PCI, that means percutaneous coronary intervention, plus optimal medical therapy with optimal medical therapy alone. And these workers said that the difference is very little. But having said that, COURAGE, that is again to inform you, that is called clinical outcomes utilizing revascularization and aggressive drug evaluation, a big term. Only those who can pronounce big names like Germans or Indians can pronounce the whole thing. Others is a tongue-twisting word. Revascularization was more common in medical therapy group than in PTCA group according to them, but the difference is that 32% versus 21%, and freedom from angina was slightly better with PTCA by approximately 72%. This is in stable coronary arteries. And you can see that after that storm in the teacup, the angioplasties and stenting came down. More people went for medical therapy, but then for the last 10 years, this has gone up again. Why? Because better drugs, better stents, and better care for these type of people with percutaneous coronary interventions. Now then came a second study, which was known as COURAGE Nuclear Substudy in 2007, where in COURAGE Nuclear Substudy, 33% in the PTCA arm and 5% more reduction in nuclear ischemia compared to 20% only in optimal medical therapy. So there's a difference of 13% with PTCA. There's an improved outcome associated with this 5% drop, especially in those with 10% or greater ischemia at the baseline. Now, current nuclear substudy supports PCI for ischemia relief in stable coronary artery. So it's a difference. The PCI-based approach was more effective at reducing the total burden of ischemia, which is good actually, measured by two things, SPECT and MPI. You know the SPECT is done in Mount E and many other hospitals now, and also MRI and many other scans, Express Reco and many things. This was published in 2007 by the American Heart Association and American College of Cardiology. Then came Barry 2D. That means bypass angioplasty revascularization investigation in type 2 diabetes in Pittsburgh, USA. Among patients with diabetes and stable ischemic heart disease, a strategy of prompt bypass surgery significantly reduces the rate of death, myocardial infarction, stroke in those with extensive coronary artery disease and impaired LV function. This is a subgroup with diabetes mellitus. Then you can see this picture. You see that this is the right coronary artery, which had almost 99 to 100% stenosis, which was treated by angioplasty. Then you can see that it looks very nice, but there was a restenosis following that. So a stent was put and the patient is well for many, many years. So that is the beauty of doing angioplasty and stenting. You can see here a coronary artery where there is a right coronary artery with you can see now it is treated with angioplasty and it is better now. So similarly, we will show you many more examples. For example, here there is a left circumflex artery which got a large number of blocks here. You can see that this was treated with angioplasty and stenting, following which you can see that this is the artery, beautiful, no more blockage and the patient is free from angina. So that is a good thing about angioplasty and stenting. Now having said that, we go for another one. This is a study overview. In a randomized trial with 2,280, I give you some statistics in between and I give you some pictures so that you won't get very much bored, In a randomized study, about 2,500 patients with coronary artery disease and evidence of ischemia, assigned to receive optimal medical therapy with or without percutaneous coronary intervention. At a median year of 4.6 years, the rates of death and myocardial infarction was 19% with the PCI group and 18.5% with the medical group. So there's a paradox. The PCI group, however, had lower rates of angina and repeat revascularization. I'm looking into the FFR. Another one is called FAME, which is FFR-guided PCI. I will show you what is FFR in a minute. Patients with multi-vessel disease randomized to routine angiography-guided angioplasty or stenting, or FFR-guided stenting in only the lesions with FFR less than 0.8. I'll tell you what's FFR in a minute. Clinical outcome was better with FFR-guided PCI. You can see here. See, the blue is FFR-guided, and the yellow is without FFR. You find out that FFR-guided PCI, that means PCI means percutaneous coronary intervention, which means angioplasty and stenting. This is a new term for it. Had lower incidence of major adverse cardiac events such as death, repeat reclassification, etc., and compared with angiography-guided PCI in multi-vessel disease. This was published in 2009. So I go into research work also a little bit. So medical therapy was a revascularization in the management of stable angina patient. Untreated coronary artery disease obviously go to progressive angina, myocardial infarction, LV dysfunction, and risk of sudden cardiac death. Goal of therapy in stable angina is one, alleviate the symptoms, and two, delay or prevent the progression of coronary artery disease, prevent adverse outcomes such as death and myocardial infarction. Accomplished with medical therapy, revascularization either in the form of PCI, that is angioplasty or stenting, and bypass surgery with or without. Interventional therapy ameliorates symptoms but generally does not improve mortality. Now, once you're born, of course, you die, so mortality can improve only very little. Then came syntax. Syntax is another test called synergy between percutaneous coronary intervention with taxes and cardiac surgery trial. I'll go into details later of syntax. But we are interested in IVUS and OCT. There are two things you can do. One is called intravascular ultrasound, and another one is called optical coherence test. So these will enhance our cardiologists like us, interventional cardiologists who are doing intervention, to see whether this needs any stenting or angioplasty. So energy is sent back. It's just like OCT uses light, whereas IVUS uses sound waves. So we put this intravascular device within the coronary artery while we are doing the angioplasty or stenting. Energy is sent back to the catheter to reconstruct image. OCT has higher resolution than IVUS. Offers evaluation of the wall structure in coronary arteries nearly to the level of a single cell. Now you can see this is the IVUS and this is the OCT. Now you can see that I'm going into IVUS for a little bit. Intravascular ultrasound image of a coronary artery with color coding. You can see that this is without color coding, this is with color coding, and you can find out whether there's a plaque burden inside or not. I'll go a bit fast so that you can answer many things during the question and answer time. Now we talk about intravascular ultrasound, provide information about the plaque, the vessel wall, and the degree of luminal narrowing. You know that all plaques are not the same. There are something called vulnerable plaque. The vulnerable plaques are thin cap plaques with a large amount of cholesterol inside. And these are the ones which will break and cause sudden heart attack. So intravascular ultrasound helps you a lot. So is the case with OCT, not OCD. OCD is a psycho. This is OCT. Actually, assessment of, so medical cardiologist is OCT, psychiatrist is OCD. Assessment of indeterminate lesions. So intracoronary Doppler pressure wires are used in PCI. So to characterize coronary lesion physiology, estimate the lesion severity, comparison of pressure distal to the lesion with aortic pressure enables determination of fractional flow reserve or FFR. An FFR measurement below 0.75 to 8, which we know how to do it because we have to calibrate with the machine, gives a better evaluation of the plaque. Now, antithrombotic therapy. Of course, we have heard about antithrombotic therapy. There are many types you can use it. Aspirin and heparin have been the traditional adjuvant medical therapy. Nowadays, of course, we have direct thrombin inhibitors like biliverdin. Biliverdin are slightly better than heparin in preventing ischemic complications during balloon angioplasty, but do not affect the restenosis rates. Then came low molecular weight heparin are substituted for standard heparin at some centers. For example, in Singapore, I understand that in Tan Tock Seng Hospital where Dinesh works, where they use a lot of low molecular weight heparin. Patients receiving stents treated with combination of aspirin, I mean Dinesh works on Wednesdays, not every day. Every day is with me in Mount Elizabeth or here. Patients receiving stents treated with combination of aspirin and clopidogrel called dual antiplatelet therapy. There are many other substitutes for clopidogrel now, like prasugrel, ticagrelor, and so on. Bare metal stents, according to them, must use minimum 4 weeks. But now we know that bare metal stent we must use 6 months of dual antiplatelet. But there are people who use even 1 year. Drug-eluting stents you must use minimum of 12 months. Whether there is any benefit for using more, we are not sure. But there are people who use for 5 years, 10 years, and so on. Now, glycoprotein inhibitors are also another drug which we use. There are many types. The common things are abciximab or Riocro, pyrofiban or agrostat, and integralin. We use a lot of integralin and Riocro. I won't go into details because these are details of the thing. Now, 5 randomized trials on a 5-year follow-up comparing angioplasty with bypass surgery with multi-vessel coronary artery disease showed that the effect, ultimate effect is more or less similar to that of PCI and bypass surgery, even though in PCI we may have to do some repeat procedures from time to time. So that's the only comparison I want to show you between bypass surgery and PCI. Now this is a 2D reconstruction image of a coronary artery using IVUS. The colored areas represent the plaque. You can see this is the plaque. Sometimes you may not be able to see this very clearly by just luminology. That means angiogram, angioplasty is a luminology. You just see the lumen only. You don't know how the plaque looks like. So IVUS will tell you how the plaque looks like. You can see that Here is called OCT, optical coherence tomography. Not everybody uses, very few of us will use this type of techniques. On the top is a normal coronary artery. You can see here the OCT shows beautiful coronary artery. The B, number 2, is a fibrous plaque, homogeneous high intensity signal without obvious borders, you can see in the arrow. Then comes the C, lipid rich plaque, area of low intensity. Then D is a calcified plaque. E is the stent application, you can see here. And F is a ruptured thin cap fibroateroma. So these two modalities, like IVUS and OCT, can tell you a lot of things apart from the simple angioplasty and stenting. This is one thing, optical coherent tomography. The stent is here in the coronary artery. This is the OCT in two modes of presentation that you can see that we can evaluate. Now, this is again a picture of the optical coherent tomography. You can see here before stenting, there is a huge TL. That means the lumen is compressed by a large intraluminal hematoma. You see, this is a false lumen which compresses this, and after the stenting, the lumen becomes like that. You see the difference? So OCT helps. If it is just an angioplasty alone, you may not be able to see all these fine qualities of the coronary artery. Now, there are many other stents. The new stents are called plastic stents. Instead of metal stents, we use plastic or biodegradable stents. There's a new thing. You put a stent, the metal is there forever in your life, but when you do the biodegradable stent, the stent will be absorbed after some time. So this is one thing. You can see here that the bottom is the optical coherence tomography and the high magnification view with the CT. Now here is the top is IVUS, bottom is the virtual histology, before stenting and after stenting. You can see before stenting and after stenting. So all these are pictures we get from our patients. Now bioabsorbable stent, there are many people have come up with many types of bioabsorbable stent. The only one we use is the Abbott BVS stent. Okay, so these are different types of material. Now, this is an angioplasty and stenting of the left anterior descending coronary artery. You can see this left anterior descending coronary artery is missing completely, 100% block. Here this block, we put a wire through this, you see the wire is coming, and then a balloon is put, it's inflated, and you can see that this is reconstructed, but there is still got a little bit of stenosis here. So what we do, we through the guide wire, we put a stent, and then ultimately with the stent you see open segment of the LAD, the artery is reconstructed completely. This is the stent we are going to put, and after the stent, the artery looks perfect. So this is what is known as complete reconstruction. You can't do it with bypass surgery. So people like us who have the fine techniques, you can see the artery. This is the stent here. You can see that after the stent, artery looks beautiful and well done. Of course, they have to take dual antiplatelet therapy for a long time. Okay, so we will now go to the next one. Now this is the technique that I want you to see. This is the radial artery. Dinesh and me does a lot of radial artery. We puncture the radial artery, the blood comes off, very little of course, few drops. Through that we put a wire, you see, pull back the needle, the wire is inserted, we put a hand there, and then you see, through this we put a sheath. This is the sheath we are going to put. Once we put the sheath, we will take out the wire. You watch and see what we do. This is a live demonstration for you, even though it's not live, I recorded it earlier on. Then we put this, very little, few drops of blood only, we don't lose any blood at all. And then we keep the sheath inside, and within that we put the catheter. This is the catheter which goes through, and under radio control, we put a wire through it, and then you can see the wire coming down. We see the catheter is being put, the wire coming through the brachial artery to the heart, and then we bend here, and then we put it in the aorta, and then at the opening of the aorta, you see this is 100% blocked artery, 100% blocked left coronary artery. Nothing can be done surgically, but we are doing it. We put a stent there. What we do is we dilate it first. This is an introducer. Through the introducer, we are putting the wire through that. You can see the fine wire, which is as thin as your hair. Well, those who got a thick hair, I mean, not people like you, he, and me. People can't hear so well, so it's all right. So you see the wire goes through. See, then we have a pump outside. With this pump, you increase the pressure to 2 atmosphere, to 3, to 5, to 6, to 10, to 20 atmosphere, depending upon how much it can take. And then we put a stent. You can see the stent there? It's going through there, and the stent is being put at the proper area. Two of us makes difference. 2 people means it'll be faster and it's better. So that's why we do, Dinesh and myself does a lot of work together. Teamwork for everybody is better, whether it is cardiology or orthopedics or whatever it is. So you see, we put a stent there, that is almost reconstructed, stent deployed at the origin of the LAD, pulling back with the pressure 24 to 26 atmosphere here, because it is very hard. We have to use a very high pressure. Normally, you don't have to use so much of pressure. And the pressure is measured by that machine outside. And we have to use our foot, our brain, and the hands together, all together. See, it is reconstructed. You look at the artery. There was nothing there. Then we pull out the catheter, and then immediately we put the bandage here. We remove the sheath immediately. When you finish it, immediately you pull out the sheath, you can see, no bleeding. And you put some air there, and that's it. See, if you do through the femoral route, which is done by most people, we do both femoral and radial. Radial require more technique, so that's why only few of us do the radial technique. And the only interesting thing is you can get up and walk immediately after the angioplasty. Whereas in femoral, you have to sit there, you cannot bend your leg for some time, and but it is more technologically challenging. You require a little bit of a learning curve, or rather a lot of learning curve. Now this I thought I'd show you. This I've shown from time and again. This is one of my patients, which was reported in the Straits Times, a 28-year-old bus driver who used to smoke a lot and used to eat a lot of mutton, and as usual, he got a family history. He had a heart attack, he collapsed. I brought him back. At that time, his heart, it was a complete blockage of the artery, so we did a bypass surgery. After bypass surgery, he survived for a while, then he had another heart attack. At that time, the bypass graft was blocked. We did angioplasty and stenting. He's doing very well. He changed his job, he got a better job. I told him, you cannot be a bus driver, so sedentary. Those days, you remember, nowadays, none of you see a bus driver and a conductor. The driver is a sedentary fellow who sits there with a big tummy on which he can write, no need for a table, I mean, such a type of a tummy. And then they smoke, they drink, so now no more. So this is the difference between jobs. Now he's working as a landscaping fellow, and I know him right up to 2012. You see, this happened in 1986, he's still alive and all right, to 2012. So that was the Straits Times picture. Now, I'm going to tell you something about the FAME2, I think still got time. FAME2 means fractional flow reserve guided percutaneous coronary intervention, plus optimal medical therapy versus optimal medical treatment alone in patients with stable coronary artery disease. In August 28, 2012, stable CAD had lower need for urgent revascularization if it is diagnosed with FFR-guided PCI plus best available medical therapy or OMT. Whereas stable coronary artery disease, as you can see this number 2, at least one stenosis with FFR less than 0.80. How do we measure? Because the machine will tell you. We don't have to calculate. But the moment you put it there, 0.8 or whatever it is will be done there. With optimal medical therapy alone, at a 4-fold larger hazard of major adverse cardiac events than FFR-guided PCI with either drug-eluting stent plus optimal medical therapy. Optimal medical therapy include dual antiplatelet therapies such as aspirin and clopidogrel, beta blocker, calcium channel blocker, nitrates, whatever you can think of. In contrast, patients with hemodynamically non-significant stenosis, FFR more than 0.8, OMT alone had a favorable result. So we can find out which one require medical therapy alone and which one require PCI. Now this is FFR. Now you may not go into details of the FFR, but you can see that when you pull out, you can see the pressure difference within the coronary artery. So this is a measurement, and these are different lesions measured in FFR. I won't go into details because this requires a lot of explanation otherwise. You can see another FFR. You see before, after the procedure, you see the difference. I think you don't need to learn FFR. By looking at it, you know what it is. Coming down here, this is straight. So at least you know that you can find out what is the best treatment for the patient. Now, in stable coronary artery disease, FFR-guided PCI improves outcome compared with medical therapy alone. This is driven by a dramatic decrease in the need for urgent revascularization for acute coronary syndromes, which includes unstable angina, myocardium, so many things. The threshold commonly said is 0.8, but there are some people say even 0.75 is associated with the sensitivity of 90% and the specificity of 100%. You know, in statistics, we always look at sensitivity and specificity. With functionally non-significant stenosis, medical therapy alone resulted in an excellent outcome. So you have to, the FFR tells us whether medical therapy alone is needed or you need PCI. Now, current era in the stable chest pain, following Courage, Berry 2 and FAME 2, which I talked to you a lot at length so far, stable chest pain, medical therapy or PCI, or you take the patient back to cath lab. Acute coronary syndrome, we remember the chest pain, we take them back to the cath lab, we do an angiogram and we of course open up and the flow is established. Revascularization does not reduce mortality, but it improves the quality of life of the patient. Revascularization reduces anginal attack and ischemic burden and improves the quality of life. Teamwork is very important. Heart care team must include the referring doctor like you, sir, cardiologist, and a cardiac surgeon. Revascularize the ischemia-producing lesion. That is very, very important. Teamwork is always important. Is it black and white or gray? This is my terminology. I'm using a metaphor. To treat all conservatively at first may be as bad as treating all patients with stents first. Some do better with stenting plus optimal medical therapy from the very start. Find out who those might be, rather than making one-size-fits-all policies. Stents don't reduce events at all, but reduce death, myocardial infarction, if they effect a large enough reduction in the ischemic burden. FAME 2 and nuclear substudy of the Courage do support this. So PCI for treating unstable angina, acute myocardial infarction, and multivessel coronary artery disease. Retrospective cohort study, they did 2 million patients with PCI. This is 2013 statistics, latest statistics, by Friedman and his colleagues. They said that transradial on the increase associated with lower complication risk than femoral PCI. Of course, you can do either, we do both. But majority of our work, 90%, we do transradial, which is better for the patient. RPCI means radial PCI, has lower risk of bleeding and vascular complications compared to transfemoral, that is for the femoral artery, after adjusting the age, sex, and clinical presentations. Growth of PCI has been remarkable for the last 10 years. No doubt, after the Courage, it dipped a little bit. Now it's back to normal, it's on the rise. Stents are now used in more than 80% of PCI in America. So, with that, thank you.
Thank you, Dad, for giving that presentation. I thought I had to say that once anyway. We're going to go to questions very soon. Just before that, just to summarize, you've heard a lot about a lot of new technologies here. Imaging technologies, IVUS, OCT, which is optical coherence tomography. These are all new techniques and require a little bit of a learning curve. You might find that some of you who are not cardiologists, when you refer your patients in, they come back, there's a lot of stuff written in about this kind of assessment, and therefore it's very useful to know what these things are. There's also FFR, which is fractional flow reserve, which basically measures the pressure gradient across a blockage. So what you have is a pressure before and a pressure afterwards, and across that blockage you see if there's a pressure dip. And if that pressure dip is more than 20%, which is what you get with the 0.8 value or the 0.75 value that was referred to earlier, then you know that that's a significant lesion. These are all new terminologies and therefore new techniques in assessing a lesion. Because in the past we just said you did an angiogram, 70% blockage or more, which is what you measure with your eye most of the time, and then you decide to put a stent in. But in this case now we have a lot of new technologies that allow us to assess things a little bit better. And a lot of it is evidence-based as well. One of the other things that was mentioned was plaque, rupture plaque, dissection, etc. So in a lesion, when you assess it with some of these modalities, even if it's not 70% and there's a dissection in that area for some reason, you may need to stent it as well. So it's a little bit more complicated these days. And one of the things is when you have more technology and more modalities for assessing the lesion, it tends to complicate your life a little bit as well. So just a little bit of an explanation of what goes on. So I would like to open this to the floor for questions. I see a gentleman with his hand up right at the end.
Just for the sake of identity, we all know you, but please identify your name so that others know who you are. And then we will get answer. Both Dinesh and myself will answer from time to time.
Yeah. Sorry, I'm Dr. Lee. I'm out of my. I'm Dr. Lee. I'm out of my field. I'm a neurosurgeon. Just one question related to cardiac. What is the role of cardiac surgeons now? Do we put them out to pasture? Do we retire them? Do we retrain them to be cardiologists?
Actually, thank you, Dr. Lee. We always will need cardiac surgeons because if anything ever goes wrong and any complications, we tend to need their work and their help. Dr. Nair had referred to the heart care team. The way things are going now is we're moving towards a heart care team where the surgeons, the cardiologists, and everybody else work together in one team. This is particularly useful for the valve therapies. We do percutaneous valve therapies. You heard about TAVI. It's basically transapical valve implantation. So that's one of the things. I'd gone to Germany to learn and do it. And we've been trying to launch that in the private sector, but it's turned out to be a little bit too costly. But especially in circumstances like this, you tend to have the surgeons on board. We work with them. We use the femoral route, pass the catheter up, and we work together. The surgeons actually use a transapical route going in to replace the aortic valve. So we haven't put any surgeons out to pasture. The surgeons have more work, but of a different kind. In association with the cardiologist, there is also this concept of hybrid therapy, where you do partial surgery and partial stenting, where you get a Lima graft from the top, pop it down, where the surgeon does minimal insertion, puts a Lima graft down, and we stent the other arteries. So the patient doesn't have a big midline insertion down the sternum as well. So there are lots of ways where we can work together with the surgeons. There is a little bit less work. The surgeons will always tell you that, and I'm sure all your friends have told you that nowadays, because all the cardiologists are stenting everything, there's less work for the surgeons. It's just that I think the work has changed to a different type. And a lot of it is valve therapies. Perhaps Dr. Nair has his perspective on this.
Well, I will use a word